So I guess I'll start by asking you this. So weight loss, when we think about weight loss today, we're not just thinking about calories in, calories out, do more exercise, get thinner. We're into a new era of weight loss, metabolic weight loss, and there's a lot that is encompassed in that term. But can we start kind of at the beginning with some basic explanations? First off, what is metabolism?
So this is a really important question that we hear more often now as we get more information. So metabolism is how your body takes nutrients that you eat and also manages its own components to give you energy and allow you to perform and to feel well. And it also controls fat storage and blood sugar. So people with diabetes, for example, don't have a healthy metabolism. But there are a lot of other people who, for various reasons, also don't have a healthy metabolism and are not aware and or have made efforts to lower their body fat or lose weight and promote health, and then perhaps haven't had as much success. We used to say, what are you doing? What did you eat? You mustn't be exercising enough. And what we've come to really understand better within the last decade is that without being diabetic or having a diagnosis of a chronic disease, you can have a metabolism that works differently than your neighbor.
Right. And metabolism's not a thing. Like, it's not a little unit in our body that turns on or off. Like you said, it's a variety of systems that are working together. Is that right?
Yeah. So it's an interaction between your internal environment and chemistry and the other things that are happening. And so even like temperature where you live, the types of food you eat versus the types of food someone else eats, other medications that you take can affect your metabolism. People sometimes are aware, sometimes are unaware. And it really has to do with, so some people have issues with metabolism, for example, of carbohydrates, where they have insulin resistance and run into some of those types of issues with fat storage. But you can have other metabolic factors that affect your ability, for example, to build muscle. So you want to look a certain way and it's not really happening, whereas your neighbor who has a different internal environment and possibly a different type of life may be having success in that regard.
Right. So today we're going to talk about intervention with medications to manage metabolic disorders or conditions. So predominantly we're looking at things like diabetes, insulin resistance, and that kind of thing. Can you talk a little bit about how weight becomes potentially more difficult to manage when somebody does have one of those metabolic conditions?
Yeah. So if you have insulin resistance genetically, or if you have already a high body fat, and or if you're a female patient in the perimenopause or menopause, you can land up in a metabolic environment that promotes the storage of fat. So the person may not have done much different, but all of a sudden they're gaining fat. And so for these people, we want to know why they're gaining fat. So sometimes that involves a bit of investigation. And then aside from the investigation and or as a result of the findings in the investigation, we may try to support them in order to get their metabolism working a little more like their neighbors.
Right.
And the management of that is multiple things, not just one thing.
Right. And is there a shift now we're seeing in medicine where we're not prescribing, or physicians and practitioners aren't prescribing diet and exercise as the primary line of, I don't want to call it defense, but like therapeutic, like resolving the issues?
Yeah. So I think what's happened, in my clinical opinion, and reading about this all the time and doing some work exclusively in this area, is that the pendulum has swung. So we've spent many years, particularly in primary care or family care, encouraging people to diet and exercise. And it's frustrating because obesity and central weight gain and metabolic syndromes are a chronic disease. And so these patients, most of the time or much of the time, haven't had great success with the loss of body weight or getting into a healthy BMI, which we may talk about a little later. So they haven't had much success, which becomes discouraging for the patient and discouraging for the clinical person. In recent years, we've had medications come into the market, specifically then on label for obesity, which has really increased increased consumer demand for the treatments, and also has been very satisfying, I believe, for most clinical people in order to have a tool that you can provide to somebody that will actually be helpful.
Right.
Meanwhile, the pendulum has swung to such an extent, it seems, with consumers and with sometimes with clinical people, where the medication becomes the standalone, where there's a prescription without much counseling around the other things that must be manipulated around that metabolism alongside the medication in order to get optimal results, and in also to avoid any negative impacts that can occur if you heavily dose a medication where someone's hardly eating, for example, and they're not maintaining muscle, and they're not being supported in terms of mental health, which is a huge part of your identity if you do have success with losing weight, especially for a person who hasn't had in the past. Those really change your life. And so there needs to be a multi-pronged approach. Definitely Obesity Canada promotes through all the research they've done that this is what needs to be happening. But I think there's just been such a fatigue in engaging with people and trying to help them and supporting them. And for a variety of reasons, we weren't getting results for so long as well as we could have, that the medication becomes like the thing or the standalone treatment, which is not going to be helpful in promoting health for people longer term. Definitely, if the patient won't exercise, you can prescribe the medication, get the body fat down, the visceral fat down, but they're not getting the full benefit associated with the other aspects of management of that condition that support cardiovascular health, mental health, strength, and well-being in old age.
So like with any condition, I suppose we're looking at it holistically in terms of best case scenario for the outcome when we're treating, right? So like you said, we're looking at mental health and all these other things as well. Jennifer, how does one know if their weight is, or their body type or their weight or whatever you may call it, is at a point where they need to start asking a medical professional to intervene or for help?
Yeah, so people tend to show up in clinical environments much later probably than they could, really because there's so many consumer-driven products and things you can buy and try and gyms and a lot of noise around it. But right now with the treatments we have, it's important for people to present clinically to be checked with the understanding that it's possible that medication may not be the most suitable at that time, but we can then monitor markers. So when you come to a clinical person who's approaching this holistically, we're going to be taking a look at, not just your numbers, but your blood pressure, weight, BMI, but also waist circumference, the type of fat you have visually on inspection as well. And then also lab markers can tell us that maybe one person is just approaching the highest sort of part of their BMI range, but they have metabolic syndrome. And so maybe they have more fat in the mid body than their neighbor who weighs the same for the same height. Maybe their blood pressure is just below the level we're going to treat. We have blood vessel concerns possibly brewing. And then perhaps their lipid profile and their glycemic profile is showing that it's not as healthy and it's not managing as well. And also that it's not optimized to support them in losing weight.
Right.
And so one may receive medication and the other one may be disappointed, but it looks like it's more possible for them to do lifestyle, and we can glean a little bit of that from the clinical evaluation.
Mm-hmm. So it's complicated, right? There's not just we prescribe it in this scenario. Like you said, there are various factors, and one of the things that you just mentioned earlier was BMI, and traditionally that's been a pretty standard marker of whether or not someone is obese and needs to lose weight, and at what point medical intervention needs to happen. How is that changing, or how do you think it should change in terms of that, relying solely on BMI as an indicator?
Yeah, so BMI is a gross estimate, and a lot of the time it gives you a fine range of weights.
Right, because it's based just totally on weight and height, right?
Yeah. Where it fails is when you have maybe somebody who's not muscular and small build that has a lot of fat in the center of their body. and they maybe aren't exceeding the top limit for their height, but compared to their neighbor who's heavily muscular, exceeds the top limit and has a body fat, they both look like they're landing in the same spot. They're metabolically completely different. And so it's one thing. We don't like to see them go low. The lower end is probably more reliable in terms of a marker of evaluating health than is the upper end. The upper end it's somewhat negotiable. The waist to hip ratio and waist circumference are really a great adjunct to the BMI, taken together. And then also now we have instruments in clinics like scales. The home ones aren't as accurate, but to see how much body fat percentage a person has, which although not prevalent in the guidelines as a metric, is another way that you can see where somebody's composition is at, whether they're mostly fat or mostly muscle. And sometimes looks can deceive you.
Yeah, I guess that would be, if you're a pretty muscular guy or whatever, and you're not really that tall, your BMI might be high, but really that's not an indicator of how you carry fat or where or how much, right?
You can be healthy. Also, people can have like a lot of visceral fat and not much subcutaneous fat, which is where you see the male patient with the expanding belly, but nothing jiggly. More common in males, but visceral fat isn't safe. So clinically, visually looking at a body shape for us, if we're working in this area, you get an idea. But the metrics are useful, and nothing in terms of calculation is an absolute. It's the clinical picture taken together.
Right. And you mentioned a little bit about that. You're not, one of the things that you're concerned about most is the distribution of the fat. And you touched a little bit on body shape and the difference between visceral and subcutaneous fat. Can you go into a little bit more detail about those things in terms of what they are and how they might contribute to your health?
Sure. So subcutaneous fat is the fat that people notice when they talk about getting obesity, or, the typical lay term of getting fat or I'm getting overweight, is the fat you can see. That fat is sitting under your skin. And that fat that's what brings people to clinic or gets them interested in finding out about losing weight. Meanwhile, visceral fat is inside the abdominal cavity. It's a pad of fat that we need and that we can feed our body off of when we're not taking in food. But that visceral fat also can crowd your organs. So the visceral fat pad increases and grows, when you're not healthy, especially if you have metabolic issues, and may or may not be in sync with the subcutaneous fat.
So you can have
visceral fat that doesn't look loose and jiggly, or that just is the belly and nothing else, but that's actually a health hazard.
Because it's around the organs.
Right.
Yeah.
Yeah. And it can crowd the organs and also contribute to sleep apnea and a whole bunch of other things because it's in the thorax, right? It's inside, and there's only so much room in there.
Right. That makes sense.
It also is inflammatory.
Meaning
that it can throw out chemicals that create an environment in the body that's suboptimal in terms of metabolism and overall.
Right. Because that's a term that we hear a lot too. And it's kind of, at least to me, this kind of mysterious term, like I'm inflamed or I have inflammation, but I'm never quite sure what that means. Does it mean excess water weight? But as you said, it's a little bit more than that.
Yeah. So that word is used as a buzzword everywhere that you read about health right now, partly because of the medications that are on the market for obesity and microdosing, a lot of stuff for which there isn't a lot of evidence, but you don't want inflammation body-wise, particularly because it has an impact on your blood vessels and your cardiovascular health. Also not great for your brain and other things, but definitely it is not optimal for well-being over the long term. You can have short-term sort of stressors to the body or inflammation or something autoimmune going on, which has to do with your own disorder or disease or malfunction, but prolonged exposure to these sorts of things creates chronic problems later. So you want to deal with that potential cause before it is a cause.
Right. And can I ask you a little bit, maybe shifting a little bit to aging and weight gain? And I know that we're seeing a lot of, stuff in the media now about women in menopause, perimenopause, gaining weight because of hormonal changes. What are the hormonal changes and how do they affect your weight potentially?
Yeah. So in perimenopause and menopause, first of all, can be up to a decade of fluctuation of hormones that lead to altered use of sugar in your body, cravings, alongside mood things and other sex hormone things that affect relationships. So it's a real storm sometimes of fatigue, poor sleep, hot flashes. All of these things together contribute to a not healthy, not good body environment. Okay. Coming and going and then gone. And the loss of estrogen itself leads to a change in the way that the body will store fat, where it will be more likely to be stored abdominally, whereas an estrogenized female normally stores around the hip and thigh, which is actually not dangerous. So it starts to go central. So around the belly, when you start to see that, that's visceral and subcutaneous usually. And that is a loss during the transition. So one of the ways that loss of estrogen can be mitigated is by putting a patient on supplemental estrogen, which creates a healthier environment for the metabolism of your nutrients and the use of the fat in your body. People tend to come a little later, I think, than they should to address that when it's going on. They're too young. Sometimes clinical people think women are too young to consider those as being contributors, but they often are. Sometimes women are still in later life childbearing and actually have this going on alongside it.
Mm-hmm.
And so, the other thing, people think that taking estrogen will help them lose weight because we talk about not having estrogen making you gain weight, but that's not actually true either.
Oh, okay.
So you can take estrogen to replace what you've lost and improve the metabolic environment back to more similar than it was before all of this storm occurred. However, it won't necessarily take weight off you, but if you make efforts to lose weight through decreased intake, trying to increase your muscle mass and possibly using the medications that are currently available, they can be more effective in that environment where estrogen's been resumed or replaced to some extent. So up to 30% more loss on medication.
Right. So again, we're looking at the whole picture. We're not just saying, well, you need to do just this one thing and there you go, you'll be all set, right?
Right. And it's a lot of the knowledge is still evolving. So it's just so nice to have some information to offer and then also some tools to offer someone who's maybe been trying really hard and not feeling great, which affects everything. Also often in that age at peak of your career and not being able to look healthy or to stay in a healthy condition that they would prefer or that they're to achieve.
For sure. And is it the same for men with the decline of testosterone as men age?
Men would like to tell us that it's the same. It's not the same. Men have more of a slow moving drop in testosterone that starts at around 30 to 40 years of age. Typical would be about 1% per year. And it still occurs. It can be quite traumatic for people. It's a little more gentle than what women have, which is a long sort of milder thing and then an abrupt end with usually a sharp drop. And so men have this, but it starts a little earlier. It goes on lifelong. And it isn't always something that they have concern for. And it isn't always something that produces the same symptoms in every man, just like with women. So some will lose energy. All of us, when we age, we lose muscle regardless of exercise, or it's harder to build and maintain. But men who are really affected will find that they're losing muscle or they can't build and maintain muscle. It affects libido. It can affect where fat storage. So just like in females, they can end up storing belly fat, which can sometimes be more visceral fat, even if the rest of the body is not large. So there are some reasons why one might replace testosterone in the male patient. And as with anything, as with the GLP medications or HRT, it's like for the appropriate patient, it may be a health reinforcing replacement. It's just less abrupt and less profound usually.
Right. And so then at what point might you consider using a GLP-1 or prescribing a GLP-1 to a patient who's struggling with weight?
Yeah. So this is not a cut and dried thing. So it looks like it is. So if you read what we clinically in terms of information about what to do and what's in the label for the drug, it's, one BMI that if they exceed it, patients qualify. And then there's a lower, if they have diabetes and some other comorbidities, we might consider it sooner. So there is that. There also now we're seeing with diabetic patients who have cardiovascular problems that sometimes it'll be recommended alongside medicines that are actually controlling their blood sugar in order to protect them from a cardiovascular perspective, which is really interesting, including heart failure. I've seen some evidence of using the medication in the management of psoriasis, plaque psoriasis, so some early evidence, as well as some evidence in like 1 in 10 women have lipedema that particularly also crops up in the menopause. So it's deceiving. It could be body fat, subcutaneous, or that. But there is also some emerging evidence that it possibly could be treating the inflammatory part of that lipedema condition, which is usually like thicker limbs with hardened fat and a lumpy appearance, different than cellulite, which is very loose. And these limbs can be sore and they can become chronically large. So there's some evidence for that. And then I've seen just small evidence in starting things around fatty liver. But if you lose weight in general, that will also improve that condition. So we're just excited to see what else comes. There are times when you might consider it sooner. In particular, somebody's getting closer to the range, and it is a BMI that's used, right? And we've already talked about how it's not exactly perfect. But if I have somebody that's getting closer to the edges of that range, maybe they don't have a disease yet, but things are moving and they're headed there and they're storing fat centrally, which is the most dangerous kind, then it might be considered to stop that gaining rather than kind of reaching a pinnacle and then having to take more off.
Right.
It's really a trajectory that if it's occurring, sometimes women go into a bit of a manufacture where they haven't changed their diet or exercise. And it wasn't bad to begin with. And they start just growing, just gaining fat in different locations than they normally would.
And that happens typically in perimenopause or menopause, right?
Yeah. And it can happen to athletes who are used to having control over their body, significant control. The big gains appear to be more common in people who are already kind of a medium build. But even marathon runners I've seen come in and be quite distressed and they start to store abdominal fat. You can't imagine the lady runs 10 kilometers a few times a week, right? But her body is used to that exercise, so that's not. And then distance training and marathons raise your cortisol, which also in menopausal, perimenopausal patients is implicated in fat storage. So exercise that's too vigorous, too, they can get into an environment where it's storing fat and don't know really what's happening, but it's because they need some HRT often, and they might need other kinds of help.
Yeah.
So it's complex and everyone's not the same. Partly because of the earlier conversation we had about the fact that metabolisms are all different. Even if everyone's healthy and does everything perfect, they're all different. They're furnaces that run on a different amount of gas. They're running in different environments and they're affected differently and more or less impactfully by things that go on.
Right. So if somebody does start taking a GLP-1, how does it work? Like, how does it make the fat come off?
Yeah. So it sounds like a miracle when it works well. We have patients sometimes who are super responders who just start and never have side effects and they do great. What it does, it delays the speed at which your stomach empties. So when you eat, you feel more full and you stay that way longer. But in the process of that going through your body at a slower pace, now if your glucose management and insulin systems aren't the best, you're now not getting dumped with a bunch all at once. It's a slower feed that perhaps
of insulin.
Better. Yeah.
Of insulin, right? Yeah.
Yeah, it's a slower feed of insulin, and the insulin then has a chance to move those nutrients into the muscle to be used for living and feeling good rather than storing fat. Okay. And so this is what you want. Your blood sugar is not going up and down. That is part of the reason that people sometimes feel more stable or better and less moody when they take the medications, because somebody who's not diabetic can still be insulin resistant, particularly if they're obese, any stage of obesity, and have fluctuations where, they're panicky and searching for food shortly after eating because the last meal didn't hit their body the way that it needed to in order to fuel them for all their functions.
Right.
That
Right. So it
body,
doesn't just make you feel full longer. It does other things internally
yes,
to help you.
diabetes medication that then doesn't allow your blood sugar to cruise upwards. That's where the drug started. So there's some benefits related to just that part of it. And then there's some discussion and work going on now around the fact that it's also somewhat anti-inflammatory. And so that's why we see it now being considered for things like heart failure and diabetics, being tried for different conditions that are inflammatory. And a lot of the autoimmune conditions are inflammatory. So we're seeing it's a potential for a variety of uses without a ton of evidence at the moment.
Right. So it seems like there's potential, like you said, for a lot to be used for a lot of different things. And I know not everybody's the same, but generally speaking, who would not be a candidate for one of these medications, a weight loss medication?
Yeah. So if a patient is getting towards the lower end of their BMI, the medications, when they work on a patient, are quite potent. And so I wouldn't be keen to put them on something that it it's going to work to a point that they're not hungry and they're going to lose weight and slip below the line. So get into a situation where now you're small, light, okay, but your heart's beating, and now we're not maintaining bones and muscle and vital functions. So you wouldn't do that. They're contraindicated at the moment in patients with a history of pancreatitis. They've been implicated in rare circumstances to contribute to that. Waiting for more evidence now that we're using it on more obese people and not just diabetic people to see if maybe those things will change. And there's certain kinds of thyroid cancers that if they're in a patient's family, they're contraindicated because in what it would be very high doses compared to human doses in the lab, they found that mice had more incidences of these types of thyroid tumors, which are actually quite rare in humans, but we always ask about them. Otherwise, I'm mindful about eating disorders and just monitoring patients. I wouldn't, um, so getting into using the medication for anyone that I see clinically also involves a commitment, like an understanding that you may need to take the medication lifelong. So financially, it's improved since the medications have become generic. And so patients can access them for, probably a good dose for less than $200 a month. However, if they're not willing, if they don't believe in lifelong medication, then we don't want to start. When you withdraw medication, there's typically a rapid regain, and the regain is more fat and less muscle than what the patient lost. You're
Right.
losing
Right.
metabolism. When you take the medication away, you're losing metabolism. At any weight they get to going up, they're actually more fat, less muscle. So that metabolism is less healthy. And it probably wasn't healthy to begin with if they were placed on medication. So lifelong commitment or not a good idea to start.
Right.
Rapid gains and losses aren't good for people either. And then I tend to want people to make a commitment to go with the program thoroughly and consistently at a moderate rate of loss, which is managed through dose changes and adding other things in, adjuncts, but a moderate rate of loss so that you are not losing a ton of muscle because you're cosmetically on a diet where you want to
Uh-huh.
be a certain size and look a certain way by a certain date, and the medicine has made it so that you're hardly eating.
Right.
So this
Right.
happens where patients are ecstatic. I don't have to eat. I didn't eat all day.
Right. Right.
So that's not a great environment to
No,
support your metabolism.
that opens up a whole other can of worms for a person's health, right? So,
Yeah, that. And then if they stop the medication, and they refeed and they're going to be very hungry, you go back to what you were. It's a regain now. The body composition, once that thing has happened, will be more fat and less muscle than what they started with usually. So you don't want to, it's not to be cruel, but you don't want to do harm by doing something that somebody really wants because they're quite distressed often about their appearance.
Uh-huh.
Society more so than health, but from a health perspective, just like yo-yo dieting is not good. This is
Right.
even worse because the cut on what you're eating can be profound, the loss can be rapid, and the rebound can be phenomenal.
Yeah. Can you talk a little bit about how then, so if someone has lost weight, how do we know when we're getting to what might be considered an ideal or a healthy weight? And then how do we kind of transition to stop losing at that point?
Yeah. So people didn't used to get to the point of maintenance most of the time
Right.
on
Right.
weight loss programs. But now I have
Yeah.
to watch to make sure people don't go under what
Right.
I think looks well, right?
Uh-huh.
Especially if we're not treating a chronic disease. So if you're treating diabetes, you're looking at glucose and A1C and all of that. If you're treating a patient who was just getting, obese and probably going to have some health consequences if we don't intervene, then when they get down into a weight that looks healthy, just visually, we repeat blood work. There's probably by then been some improvement in their hemoglobin A1C and their cholesterol markers, which your heart and vessel health is intimately linked with all of this. So if those have improved, and the weight, like people often know what their good adult weight was before they gained, especially females, because it usually occurs somewhere later, 40 and up. So if they know their healthy adult weight, we'll kind of look at that and decide. Sometimes just cosmetically, the healthy adult weight at 28 looks terrible at
Mm.
48 or
Yeah, it's
53.
different. Yeah.
We can add 3 to 5 pounds, even if the composition's unchanged, and have a patient that looks well, or shoot for that weight where they probably had a lot more muscle,
Mm.
active in
Yeah.
sport or whatever.
Yeah.
And then also because of facial structure, they'll look gaunt, but that's still not healthy, like health risk. But it's what is, you want to be, it's part of your self-esteem. That's why I insist patients go for counseling while they're going through it, because you get a better self-esteem, but it affects your relationships. And if you really lose weight, your position in the world changes and how you perceive it, what you can do, all of this. But it's really somewhere in the happy place, provided the happy place isn't an unhealthy place.
Uh-huh.
But often it's a little higher than people think because of what happens to the face, particularly in females. And then
Right.
there's cosmetic treatments we can offer that help with that. So if they're at an unhealthy weight still, but the face is looking unwell, we can, use biostimulators and a few things and get the body to a healthy weight with
Uh-huh.
looking good in their
Right.
age, which is also important to people.
Right.
So when you get in there, we can either, sometimes it plateaus itself, which is why you don't want to not take the program seriously, being exercise and muscle building, your mind,
Mm.
your medicine, because
Right.
at some point it can actually meet its natural endpoint. And so then if a patient is on semaglutide, which is, Wegovy brand, we
Uh-huh.
can possibly now move them to a second agent that's newer, more expensive, that's a little more potent or that acts a little differently, and then sometimes keep it going. But there's a natural endpoint where the loss, even on a full dose of medication, closer to a normal BMI or not quite, it may go and stop. And so at that point, you could leave them on the same dose. They're
Right. For
not
maintenance.
using on the same dose. Yeah. So the maintenance
Yeah.
dose. And so what happens is there's this psychological thing that goes on with people,
Uh-huh.
partly because when the drugs came, even clinically to some degree, we were really pushing diet and exercise, and you need to diet and exercise first. And part of the guidelines, we still talk about diet and exercise, but we can start the drug while someone's trying diet and exercise.
Right. Right.
Because we know that based on their diagnosis of obesity and their likely metabolic syndrome, or we've seen it, that the diet and exercise could use some help, or it's not going to get them to the end point, So,
Right.
but psychologically, patients think that they should be able to do this with diet and exercise because people who've had weight problems have been told this all their life and failed.
Uh-huh.
They
Uh-huh.
think now, because it was easy to lose weight on the medication, that they can get rid of it and diet and exercise will work. It may and may not. It needs to continue to happen for health reasons and mental health reasons and other reasons. It's part of it. But medication, especially where you've had that much chemical control over your metabolism for a long time and you've plateaued, the medication's likely still going to be required.
Right.
And
There's
they're
kind
going
of been a stigma though too that people are struggling with, right? Like that a GLP-1 is like a shortcut or the easy way out, and it's kind of been stigmatized to be something negative. Whereas we don't do that with other medications that people need,
and
right?
it's
So it's
clinically we've done the same, right? And
right.
your guidelines really focused on try this for a period of time. Well, I don't know a single obese person who hasn't tried at least several cash
Fair
programs,
enough.
like all kinds of things being delivered to the home. Maybe we're competitive in sport even as young people, and nonetheless, if the metabolism's not working effectively, that may work. Sometimes it works, but it often doesn't work.
Mm-hmm. And may take a long time, and in the meantime is doing more to everything out to your health
Well,
by not
and
losing weight.
multiple attempts impact your metabolism further.
Right.
So on and
Right.
off is worse than going on a medication that I'm, slowly going to adjust over 2 years. We'll set the timeline at 2 years or 3 years,
Yeah.
and still might meet an endpoint before we're satisfied with the cosmetically with the weight and or even metabolically. So it's used before bariatric surgery, for example. Like it won't necessarily bring the patient to the goal or the health protective composition.
Mm-hmm. Jennifer, thank you so much for joining me today and enlightening us a bit about the new trends in weight loss, particularly GLP-1s and so forth. I appreciate your time, and it was great to chat with you.
Well, thanks so much for having me.